So there are some risk factors, namely extreme of ages, people taking beta blockers, calcium channel blockers, diuretics, SSRIs. These you see are very, very common drugs, very common. Hypertension, beta blockers, ECBs, these are very common drugs. Then substance of abuse, cocaine, amphetamines, ethanol, namely alcohol. So all these are more vulnerable to the side effects of heat-related illness. At risk are also laborers, military personnel, or athletes because of their poor conditioning and lack of acclimatization. Occlusive clothing is also a very important factor. So heat-related illnesses are a spectrum which range from an innocuous condition such as prickly heat to increasing degree of severity, namely heat syncope, hyperventilation tetany, heat edema, heat cramps, and then there are two big, most dreaded condition, heat exhaustion and then heat stroke, with highly lethal conditions. So let's see them one by one. Prickly heat, scientifically called as Miliaria rubra lichen tropicus or Ghamori in Hindi, is a maculopapular pruritic rash secondary to the blockade of sweat posed by the debris from macerated skin. And the predominant symptom is pruritus. Usually it happens in children with poor hygiene, wearing tight clothes, non-cotton clothes, and treatment is very simple. We give antihistaminics, chlorhexidine cream can also be used. We can advise people to move away from heat and wear breathable clothing and loose fitting clothing. Then we have a condition called as heat edema, and it is secondary to the cutaneous vasodilation as a compensatory mechanism against heat. Also, there is a slight increase in ADH, and it results in mild swelling of heat in hands and feet. And usually it occurs in early summers, and it resolves in 4 to 5 days. Nothing much is required. You should not endeavor to give a person as diuretics, not really useful. In fact, they can cause volume depletion. Then we also have a condition called as hyperventilation tetany, because in order to lose heat quickly, some people hyperventilate in heat in this condition, and already their calcium is on the borderline, so they can develop a precipitous decline in serum calcium level, thereby leading to a carpopedal spasm. Not much is required except for moving away from heat and reassuring them so that they don't hyperventilate. In worst case scenario, we can give calcium also. Then we have something called as heat associated cramps. Very commonly you must have seen unacclimated individual doing vigorous exercise and replacing fluid loss with copious water rather than putting electrolytes in. So these are intermittent, painful, involuntary contraction of skeletal muscles, and usually self-corrected by resting in a cool environment. If the need be, oral or IV electrolytes may be used. Half a teaspoon of salt in 1 liter of water, and these pass off quickly. Then in some cases you will see, especially in school children during assembly, you will have cases in which there is a loss of consciousness. कि भाई धूप में खड़े हुए थे और अचानक से गिर पड़े. So this is because of two mechanisms. The pathophysiology is such that prolonged exposure of heat causes cutaneous vasodilatation. All of a sudden, there is a change in posture. Then there is a postural drop, and people fall down because of heat syncope. The treatment is very simple. You have to put a person in shade, raise his or her leg, and rehydrate him or her. Then we come to the relatively much more severe condition. This is heat exhaustion and heat stroke. First, we will discuss about heat exhaustion. Heat exhaustion basically are of two types: water depletion and salt depletion. Water depletion occurs in people who are somewhat acclimated to heat. So they are laborers, athletes. Somehow it is shown that their thirst reflex is blunted. So if a factory worker in damp environment, in a very hot and humid environment is working for long hours, if he has done this work for months and years together, somehow the thirst reflex gets blunted. So this kind of people will present to us with both water as well as electrolyte depletion. However, in cases of unacclimated person who have just been exposed to it once or twice or thrice in their lifetime, They cope up with the heat by consuming large amount of water or things which are hypotonic, doesn't contain adequate amount of sodium. So this is, they develop side salt depletion variant of the heat exhaustion. And the sign and symptoms are milder than heat stroke: headache, vertigo, ataxia, impaired judgment. And we can also have some interesting gastrointestinal symptoms. So we all, whenever there is a heat exhaustion, we all think there'll be neurologic symptom, but we should always pay heed to gastrointestinal symptoms also, like nausea. People may have loose motions also. Previous is hypotension. People can have tachycardia. When we do lab investigation in these cases, we get very unexpected lines: low sodium, high PCV, and in some cases, the SGOT-PT can be slightly raised. If we do their urea, sodium, and chloride, they are less as a uh, compensatory mechanism by the kidney to preserve the electrolytes. Treatment is simple. We have to remove the patient from a heat stress area and aggressively cool him or her until the core temperature. And this is that thing which I keep on repeating again and again. All heat related emergencies, the only temperature which is of value and which should guide our clinical decisions is core temperature, which is the rectal temperature. So we cool him or her up to 100, between 101 and 102 loosely put. And we infuse him or her with rapid IV fluids and guided by his electrolyte determination. And one thing is very important: we should not try to correct the serum osmolarity too quickly. It may be disastrous for a person, so we should go slow about it, no more than 2 milliosmoles per hour. And lastly, I've written the serum osmolarity. I've Indianized the formula given in Harrison: 2 times sodium plus plasma glucose divided by 18 plus urea divided by 6. Because in Western books, it is 1 divided by 2.3. So this is urea divided by 6. Then heat stroke and heat exhaustion have a lot of overlapping features. But the basic pathophysiological difference is that in heat exhaustion, some kind of thermoregulation is still maintained. But in heat stroke, which is the most lethal of all, there is a total and absolute loss of thermoregulations. And besides, in heat strokes, you will more often than not, we get loss of consciousness. Heat exhaustion, we may get loss of consciousness, and in heat stroke, we may not lose consciousness also. Both opposite can happen also. But in overwhelming number of cases, heat stroke is loss of consciousness, and heat exhaustion is very, very tired, ataxic, faint, dizzy, that kind of person. So now we come to the most dreaded of all complication of heat-related illnesses, which is heat stroke. And it is a triad. 3 conditions are required to be met in order for us to declare a person of having suffering from heat stroke. These are exposure to heat stress. Now, this is a relative term. So we have to factor in all the things: heat, surroundings, airflow in and around that person, a factory worker with no cooler, no water to drink, factory covered by all sides, no windows. Even at 38 degree, we will mark it as heat state. There is no fixed temperature. You have to use your clinical judgment. Then 2 symptoms are easier. CNS dysfunction has to be there, and the core body temperature has to be more than 105 degree Fahrenheit or 40.5 degree centigrade. If these 3 criteria are met, then we label the person as having heat stroke. And now these are of 2 variants: classic and exertional. Exertional are more commonly seen in laborers, military personnel, more in exercise setting. In this, we have a kidney injury is immense, rhabdomyolysis is a lot. So we'll have very, very high values of CPK, and electrolyte disturbances will be more robust. Whereas in classic heat stroke are seen in elderly, children, people on medicine, having sedentary lifestyle. So these kind of people will have a relatively lesser CPK rise and electrolyte imbalances. And the poor prognosis markers are if an initial temperature is more than 106, and if the temperature persists to 102 degree Fahrenheit despite aggressive cooling measures, coma duration longer than 2 hours, pulmonary edema, delayed or prolonged hypotension, lactic acidosis, SGOT-PT more than 1,000, acute kidney injury, and moreover, a pre-existing disease such as diabetes, bedridden. These are harbinger of adverse prognosis in patients. And delayed therapy, the mortality rate is up to 80%. Early cooling, mortality rate drops down to 10%. So that is the reason we emphasize so much on early cooling, field cooling measures. And general physical examination in heat stroke is people will have tachycardia with wide pulse pressure. Hypotension can also be seen, but before uh, most important factor is to cool them down. This will help in settling hypotension, obviously, besides giving him or her fluids. So in CNS, we can have irritability, delirium, confusion. Usually, more often than not, they'll be confused. इधर उधर का बोल रहे होंगे. They'll be agitated. More, we had 75 cases this year. All were absolutely. Some people came very low in even V1, F1. Overwhelming number was irritable, difficult to manage, aggressive. Then we can have ataxia, tremors, dysarthria, and very sick cases may have decorticate or decerebrate posturing also. We can have cranial nerve abnormalities. And important to notice, pupils can be normal, dilated, and pinpoint. All three variants can be seen. So this is very important when it comes to differentiating it from a pontine stroke. Then in CVS, we usually have tachycardia, and a hypodynamic state can also be seen secondary to volume loss. And CVP should be our guiding principle in order for fluid resuscitation. We can also